Now let's break down deviations and exercise prescription. So again, common deviations that we've talked about before. Foot slap indicates weak dorsiflexors or neuropathy. We want to treat with dorsiflexor strengthening and gait retraining. Trendelenburg indicates weak hip abductors. We want to treat with frontal plane stability training. Again, examples, lateral band walks, and also clamshells. Vaulting or circumduction indicates poor limb clearance. We want to treat with range of motion, strength, and timing, especially in the hip flexion and knee flexion, with using high knees or step-ups. Excessive pronation suggests foot instability or proximal weakness. An intelligent gait pattern reflects pain. Again, we want to treat the pain first, wherever that may be. Hip-related deviations. Trendelenburg, trunk lean, and limited terminal stance, hip extension indicate poor hip control. Some ideas for corrective exercises include gluteal strengthening, such as side-lying hip abduction, to progression of lateral band walks, to then a progression of step downs. Hip extension drills, such as doing split squats or resisted terminal stance. And then single limb stability with frontal plane control, starting off on even surfaces and then progressing to uneven surfaces. These must progress into gait tasks. Knee-related deviations, excessive knee flexion, genu recurvatum, and valgus collapse reflect poor knee control. Corrective exercises including quadriceps control, starting with a basic TKE, and then going into sit to stand progressions. Eccentric quad loading, such as decline squats, and also step downs. And then alignment retraining during functional tasks, especially with squats and normal mechanics. Ankle and foot deviations. Foot slap, early heel rise, limited push-off, and excessive pronation all reduce gait efficiency. The corrective focus includes dorsiflexion mobility, such as weight-bearing lunges to focus in on increased dorsiflexion, progressive plantar flexor strengthening, such as doing double limb heel raises, progressing into single leg, and progressing single leg with weight. And then foot intrinsic activation, such as a short foot, or also known as doming, and then also doing toe control, such as toe yoga. Gait retraining strategies. True gait change occurs with treadmill walking, using external cues, and also video feedback. The progressional model, and what we base most physical therapy concepts off of, is going from an isolated impairment to functional strength to task-specific gait retraining. The key takeaways from this lecture is gait analysis is hypothesis-driven. We always want to observe first in our evaluations, test to confirm, and then you want to treat purposefully. Clinical impact matters more than perfect biomechanics. So in summary, normal gait is efficient and coordinated. Ground reaction force explains external demands. Center of mass explains energy cost. Muscle activation explains timing. Deviations guide your treatment. Clinical application bridges theory to patient care. These resources support everything discussed in this lecture and should be used to deepen your understanding beyond the classroom. If you guys have any questions, please email me, or I'll see you in class.